Bismillah ar-Rahman ar-Rahim. I'd like to share very sweet November night with you all. I love you all. You are my great professor, exceptional professor, Professor Dr. Ansari, Professor Dr. Askalani, Professor Dr. Makharit, and all my colleagues. Hello, everyone. I'm so in very deep emotions, so excuse me if I lost something. I'm very happy. I am a great honor to be with you this night. Thank you. I'd like to thank my great brother, Dr. Saad Mahdi. Thank you. I am honored to introduce Dr. Barbara Rogers, Associate Professor of Anesthesiology, Ohio Medical Center, Columbus, Ohio City. The topic about a complication associated with anesthesia transport of a pediatric patient. Welcome, Dr. Barbara. Welcome.
Thank you. Let me get to my share screen here. Thank you for inviting me. This is very nice. I'm going to talk about an article from Anesthesia and Analgesia from this summer. I am not a pediatric anesthesiologist, but I think the topic goes for adults also. I'm from Columbus, Ohio, and this article is going to be a review of an article. Let me see here. And the article's name is Complications Associated with the Anesthesia Transport of Pediatric Patients, an Analysis of the Wake Up Safe Database. The author is B. Hayter et al. From Anesthesia and Analgesia, July 2020, volume 131, number 1. And so this Wake Up Safe database, which is not showing up very well, but it's a database of multiple institutions in the United States. And they agreed to put things into this database, and it's scrubbed, and you don't know who put what data in, but you're able to pull the data back out and analyze it. So that's where they did how they got the data that you can't see it. So I'll just read through it, and I'm sorry no one can see anything. But
I will tell you.
So the author's study objectives were to review the database, Wake Up Safe, and delineate the risk of pediatric patients that occur during transport phase of anesthesia care. Author's goal was to educate anesthesia providers on the dangers of transport and the possibility of alternatives to consider to mitigate these risks. So what is Wake Up Safe? It's a certified patient safety organization for pediatric anesthesia. There's 35 institution members as of July of 2019. It's a quality improvement collaboration. It's a confidential registry of adverse and sentinel events at member centers, and there's 35 members, and they're all in the United States. So event reporting in the registry. The institutional groups screen all possible events and submit those that reach the appropriate criteria. Events categorized as certainly preventable, likely preventable, unlikely to be preventable, certainly not preventable. The Institutional Review Board, the IRB, utilizes is used before they put data in the database. Institution identity is confidential in the database. All protected health information is removed from the data, so it's all scrubbed. Because all the data used for this study is not identifiable, the authors did not need to get any patient consent to do their study. So database serious events. What they did is they pulled data that was within 24 hours of the end of anesthesia, and they looked at deaths, life-threatening injuries, disability, and prolonged hospitalization. So the pediatric transport associated adverse events. They looked at related to the time period of transport, things that occurred immediately before transport, either during transport, after transport, include moving patients from the preoperative holding area to the operating room, also moving to and from the ICU, moving patients to a bed or to an operating table, and positioning the patient on the operating room table. The methods, again, they mined the data, December 2017. They screened the data. How did they screen the data? They searched using free text. They used things like lift, carry, slide, etc., to pull information out of this database. Then they went over these selections by hand. They had a manual review of potential events by a group of anesthesiologists. They classified the events into certain groups. And then they had a special subgroup of all infants that were aged 6 months and younger. The results. They started with 2,971 events in this database. 1,896 events were chosen as transport related. They did a manual review and they revealed that 167 events possibly met the study criteria. The final review left 148 events for their study. This 148 cases represented 5% of all the database events. 40% of the cases involved infants that were 6 months old or less, and this was about 7% of the database. 52.7 events, they determined that anesthesia care was determined as a cause. 59.7 events declared potentially avoidable, and these were ASA 3 and or higher were involved in the majority of cases, although these are only 30% of the database. Types of events that they recorded. They did death, cardiac arrest, respiratory events, medication events, equipment events, and something they called other. Deaths. 13 reported transport-related pediatric deaths were found. 3 were ranked as possibly preventable. The root cause in all cases include underlying medical condition. All possible preventable deaths occurred in congenital heart patients. These preventable ones were stratified to have a significant learning potential. Associated factors in these deaths were listed as technical errors, time pressure, failure to act, failure to obtain more information, clinical judgment, and clinical decision-making. Cardiac arrest events. There are 86 total cardiac arrest events noted in this database. 50 cases were considered under the respiratory tag, and they said these were related to airway reactivity, airway obstruction, hypoventilation, unplanned extubation, and one reason they weren't really sure of. 30 cases were under cardiac care. They had myocardial dysfunction, pulmonary hypertension, bradycardia, tamponade, and moving the patient. 5 cases were listed under the medication reasons: interruption of vasoactive medications, unplanned medication overdoses, syringe swap events, side effects, and overdoses. And 1 case was they put under the unknown. They really didn't know what happened. They couldn't figure it out from going back over the database. So the respiratory events, 95 respiratory events met this inclusion. Let me see, respiratory events. 15 were unplanned extubations, and 14 were in infants less than or equal to 6 months old. 11 were in infants that were less than 4 kilograms in weight. 3 preoperative obstructions happened immediately after neuromuscular blockade was given. 2 happened after changing from the ICU to anesthesia ventilators. Other respiratory events were listed as bronchospasm, trach change, unknown subglottic stenosis, pulmonary bleeding, pneumothorax, negative pressure pulmonary edema, and residual neuromuscular blockade. Medication events. There were 10 medication events that they listed. 2 were syringe swaps. 1 was a vasoactive drug bolus after the line was unclamped. 3 events were inadequate handoff lead to additional antibiotics that were already given. 1 case residual medication left in an IV, and then subsequently someone opened up the IV and the patient got a bolus of this medication they didn't know was sitting in the IV tubing. 2 cases of medication pump programming error. 1 case of vasoactive agent running out during transport. Equipment events. 5 equipment events criteria. 2 cases involved changing ventilator types. 1 case involved temporary pacemaker failure. 1 case involved transport monitor falling on a patient. And the 5th one, they didn't describe what happened, but they said it was a equipment error. And then they had 5 what they called other events. These were 5 seizures. 3 led to neurological injury, and 2 seizures in patients with pre-existing seizure disorder. And 1 of these patients had missed their scheduled anti-seizure medication. So then they did a root cause analysis of all these events. They did a primary cause and a secondary cause. Primary cause was usually patient disease, and secondary cause were provider related things. So continuing on the root cause analysis, provider factors. These are the provider factors they came up with. Inexperience, cognitive bias, judgment, technical errors, task overload, failure to follow protocols, failure to act or gain more information, distraction, time pressure, verbal miscommunications, information not communicated or misunderstood, medication errors, failure to follow protocols, and other things they noted were long transportation distances, misuse of equipment, and poor equipment design. So the take-home points they came up with were: check your endotracheal airway positioning and adequacy prior to transport. Understand the ICU ventilator and the anesthesia ventilator are different. They have different settings and they're capable of different things. Confirm that you have backup emergency equipment available. Be vigilant in the risk of inadequate or lost information during handoffs. Maintain adequate supervision during handoffs. Understand the risk of medication pumps, proper programming, battery life, and where it is going to be located on your transport cart that doesn't fall on your patient. Patient movement on the cart should be anticipated and planned for. Protect cords and tubing during transport so things aren't pulled out or ripped off the transport cart. Review any equipment that is rarely used and that you don't understand. Ask for assistance if needed. 5% of the adverse events in the study were transport associated in the category of respiratory. So, and then their last point was consider that some patients should not be transported at all, that perhaps the patient is so unstable and they are in so many life-supporting devices and drips and things that maybe you really shouldn't be moving them. And so that's all I have. Thank you.
Thank you so much.
And I'm sorry about the
oh, not at all, Barbara.
slide.
Thank you very much for that. You're great. And it's very honored to have